My name is Ben Berman. I'm from the University of Chicago, and I'm going to be sharing with you the results of an abstract that we presented at the ASCO 2020 virtual conference. This is focusing on measurable residual disease, which is also known as minimal residual disease. And just a little bit of background about why we focus on MRD, which is how I'll refer to it from here on forward. Traditional measures of response are really becoming less useful nowadays because many of our treatments are able to get patients to a point where they are able to achieve excellent responses by these traditional response criteria. So things like a very good partial response or a complete response are terms that you may have heard of. Now, minimal residual disease, MRD, goes deeper. And what we're able to do is now we have the technology to look at as much as 1 to 2 to 3 million cells, and sometimes even more than that, and be able to pick out an abnormal population of cells, the myeloma cells, as small as 1 out of 1 million. Now, most of these tests are done using bone marrow biopsy and aspiration. So we take a bone marrow sample. And there's a couple of different issues that may come up with doing a bone marrow biopsy. So the first thing is that myeloma is known to be a patchy disease. So if we don't get just the right area, we may not capture an accurate representation of what's going on with the disease at that moment in time. Secondly, more and more studies that we're doing now, we take more and more aspirate from each procedure when we do a bone marrow aspiration. And what happens is sometimes the samples can get dilute. And so that limits our ability to analyze those samples. And then the third thing is that with many of our newer treatments, when patients relapse, oftentimes what we'll see is something called extramedullary disease. Essentially what that means is disease that's outside of the bone marrow. So the bone marrow may look clean, but there's disease elsewhere. So there's been a lot of interest in trying to find a type of blood test, a peripheral blood test that can be taken just like a regular blood draw, that might better represent what's going on with the myeloma, because the peripheral blood is sort of like the common ground, where whether you have disease in the bone marrow or elsewhere, you would be able to detect it in the peripheral blood. And we actually have a test where we do that already. It's called the serum protein electrophoresis and immunofixation. This is a fairly low sensitivity test that we use more for diagnosis and monitoring of treatment, but mass spectrometry is a new technology that appears to have a much higher sensitivity than SPEP, which is the serum protein electrophoresis. To speak a little bit more about mass spectrometry, the idea is that each plasma cell, which is the cell that is the culprit in myeloma, they make immunoglobulins, which are a type of protein. They're actually antibodies. And each protein that is made by the plasma cell is essentially, they're identical to each other, but they have a very unique structure, a very unique weight or mass to them. And what we're doing with mass spectrometry is we can actually drill down and look very specifically for that specific protein that keeps appearing. And what we do is we take a baseline sample from a patient when they were diagnosed. And what we can do is kind of lock in on that signature and track it over time. So whereas bone marrow testing that we've been doing up until now looks for abnormal plasma cells, what we're doing with mass spectrometry is looking for the abnormal protein product that is being made by the myeloma cells. And if that protein is present, then it will produce essentially a spike above the background of the other proteins and antibodies that are being made by the body. And so what we set out to do in this study was to actually compare mass spectrometry as drawn from the peripheral blood to one of the techniques that we use in the bone marrow called next generation sequencing, which is able to detect, like I mentioned before, 1 out of 1 million cells. And the idea here was to see how much agreement there was between these two tests, ultimately to see if a peripheral blood test might be a way to do what we call kind of a liquid biopsy. And so that's what we set out to do in this study. And what we did is we actually used samples from a prior clinical study of ours, which you can see under the methods here. And we used a regimen called KRd, And these patients received a total of 18 cycles of KRD in addition to a stem cell transplant. And we took samples at the end of those 18 cycles of treatment. And then we took samples again 1 year later when they were on lenalidomide maintenance therapy. And we had matched samples, paired samples. Every patient had an NGS sample from the bone marrow and a peripheral blood sample with mass spectrometry. And there are a couple of different ways to do the mass spectrometry test. We looked at 2 different ways. This was performed by the binding site group, the mass spectrometry, and the NGS was performed by a company called Adaptive Biotechnologies. And what we found is that for the most part, these tests, they do have a decent amount of agreement, but what we did find is that mass spectrometry was able to pick up disease in several patients where the NGS test from the bone marrow was saying that it was negative. Now, there's no way to know for sure if we had what we call false positives, meaning that the peripheral blood was picking up something that wasn't really there. It was an error. But one thing that we did look at was to see what happened to the patients who had a positive test on the peripheral blood versus those who had no disease detected on the peripheral blood. And that's what we're looking at with this curve on the bottom right of the poster, where it says progression-free survival. And what we found is that patients who were negative with both tests essentially had a longer time free of disease progression or death compared to the patients who were only negative by the NGS test. So let me rephrase that because that can be a little bit complicated. What that means is that in this small study, peripheral blood testing using mass spectrometry seems to be a better indicator of how well patients are going to do in the long run than just next generation sequencing alone. Now, I want to caution people about drawing conclusions from this test, from this study, because this was a small number of patients. We had 36 patients total. And on top of that, the NGS technology has improved over time. So many of the samples that we used, about 2/3 of the samples that we used, did not get that 1 million mark of cells. They were in the hundreds of thousands, but not quite 1 million. So it would be interesting to know moving forward how these two compare when we use that 1 million or 2 million mark for next generation sequencing. This paired nicely with another abstract that was presented comparing another technique in the bone marrow called flow cytometry that was presented by a Spanish group. But they also showed similar findings, which is that all of these tests are truly complementary. That if we use peripheral blood and we use bone marrow testing, we can really get a very holistic picture of what's going on in the body at any given point in time to be able to say if the myeloma is still there or if we really are MRD negative, meaning no evidence of even microscopic or minimal residual disease.